Welcome to the 5th ZPA webinar of the year. My name is Dr. Helen Muhango. I'm a pediatrician at UTA Children's Hospital, and I'm also the Research and Publication Secretary for the Zambia Paediatric Association. So this afternoon, we are privileged to have the team from Newborn Support Zambia presenting on a topic entitled Scaling Level 2 Newborn Care. What's happening on the ground. So without further ado, I'll introduce my co-host, Dr. Mbozu Sipalo, who will give us a brief background of what Newborn Support Zambia is all about. Dr. Sipalo is a neonatal clinician, research assistant at the London School of Hygiene and Tropical Medicine. She's also a co-lead in newborn toolkit knowledge management. She's actively involved in building a community of practice for small and sick newborn care for developing countries. She's passionate about fostering collaborations, partnerships, and knowledge sharing in newborn health space. So Dr. Sipalo, you can please go ahead and give us an overview of what Newborn Support Zambia is all about and overview of our program.
Thank you, Dr. Helen, for that warm introduction. And good afternoon, everyone. Thank you for joining this really dynamic and collaborative webinar between the ZPA and Newborn Support Zambia. So today's webinar will cover a lot of interesting things in the newborn health space. So we're basically going to talk about level 2 newborn care and where Zambia is at the moment. We have a great array of speakers from Dr. Helen, Dr. Kunda, Mr. Silavoy, and other speakers such as Dr. Leah, Samantha Munangandu, and Priscilla Muziamba. And we cover different cadres of specialty from clinicians to neonatal nurses. So this webinar is a collaborative webinar between the Zambia Paediatric Association and Newborn Support Zambia. So just about Newborn Support Zambia, who are we? It's a not-for-profit NGO registered in 2016 under the Register of Societies, and it consists of health workers working in Zambia in the newborn health space who lobby and advocate for newborns. And I'm sure a few of you here have taken part in the walks on marathons on World Prematurity Day as one of the flagship events for Newborn Support Zambia. And this, I believe, might be the first collaborative webinar between ZPA and Newborn Support Zambia, but Dr. Kunda can correct me. But yeah, we'll hear more about Newborn Support Zambia through this webinar, and thank you everyone for joining us. All right, so the agenda today, you see it on your screen now. I will gladly introduce Dr. Kunda Kapembwa, who is a pediatrician and neonatologist, honorary lecturer at the University of Zambia School of Medicine and School of Nursing, training neonatal nurses. She's a convener for the postgraduate diploma in neonatology under Zambia College of Medicine and Surgery, and she co-founded Newborn Support Zambia, a not-for-profit, non-governmental organization to help improve the care of neonates in Zambia. Over to you, Dr. Kapiri.
Thank you very much, Mbozu, for the kind introduction. There's a bit of background noise. I don't know if the host can mute everyone. Okay. Thank you very much. Thank you for the kind introduction. So I'll go straight into talking about the levels of newborn care services in Zambia. So I think to start off, we've heard of the SDGs, we've heard of ENAP targets, and when we talk about the SDGs, SDG 3.2 specifically, we're talking about reducing newborn mortality to as low as 12 per 1,000 live births by 2030. And then the ENAP target follows, because when we look at the high neonatal mortality, it starts to appear that the group of babies that was driving a lot of neonatal mortality were the small and sick newborns. So there was an ENAP target, every newborn action plan target 4, which aims at achieving 80% coverage of level 2 care for small and sick newborns at district level. This is something that we have signed to as Zambia. And there was a global report on transforming care for small and sick newborns, and this actually called for urgent actions to strengthen care of the small and sick newborn at all levels. Subsequently, we adopted the WHO standards for improving quality of care for small and sick newborns, and there was a framework to achieve this. On my next slide, you will see that working together with WHO, UNICEF came up with this model of care for small and sick newborns. And really, when we are talking about model of care, we are considering the fact that there are certain core concepts that should actually be used to scale up. This will include leadership, financing, human resource, availability as well as capacity, infrastructure and design, equipment, commodities, robust data systems, what referral systems we have, linkage to mother and newborn care, as well as the family community support and the post-discharge follow-up. When you look at the things that are supposed to be implemented, we are really starting from birth to having a baby being resuscitated properly, being kept nice and warm, being put in KMC position, is this baby breastfeeding, and all the little complications, and most prominently, respiratory support. So in view of this, WHO came up with levels of care. You can go to the next slide. So when you look at the levels of care, we look at level 1, level 2, transition, and level 3. So this is just to stratify what care should be at a particular facility so that these small and sick newborns are actually saved. So when you look at level 1 WHO care, you're talking about immediate and essential newborn care. So this is really the usual drying, stimulating, delayed cord clamping, some bag and mask resuscitation for those babies that need it, early breastfeeding, and the prophylaxis that we talk about. Then when you look at level 2, we are really saying, as I said in the previous slide, we are talking about management of the small and sick newborns. And this will even include, prevention of hypothermia, treatment of jaundice, phototherapy, looking after babies with encephalopathy, like those with HIE, and then, of course, CPAP, the minimum of CPAP as respiratory support. Then you have the transition phase. This is between level 1 and level 3. And in the transition, there's follow-up of at-risk neonates, exchange transfusion. And then when you go to level 3, you're really now talking high-tech, the smallest babies, the sickest babies that may not have had a chance at level 2 care, but are actually referred to a level 3 care, which would even allow for advanced feeding as well as mechanical ventilation. So these are WHO levels of care. When we made our standards of care, that's next slide. When we made our, it looks like the screen has dropped. Okay, great. We can move on to the next slide. So we made these service standards for health institutions providing neonatal care in Zambia in 2020. This time, these WHO standards had not come out. They were standards from other countries. And so we adopted the South African standards, and then the WHO standards came out. So I'll just take you through briefly on what is in our service standards. You can go to the next slide. So with our standards, you notice that we have primary health care, we have secondary level, we have tertiary level, and we have quaternary level. And in the primary health care, we actually have district hospitals, we have health centers, and health centers even conduct deliveries. And then the district hospitals became CMOG sites where operative deliveries would actually happen. And then you have health posts. Then under secondary, we have the general hospitals, and tertiary have centrals, and quaternary are specialist hospitals like UTH. So we decided that, next slide, we decided that in order for us, next slide, in order for us to align properly, we said, let's have level 1 care at level 1 facilities. Let's implement WHO level 1 care in our level 1 facilities, which are primary facilities. But then you notice that the district and the health centers provide different things. So we actually named them, as you would see in the next slide. But basically, in a level 1 care, this is the minimum requirement for any facility that provides inpatient maternity care. And the institution must have personnel and equipment that will actually perform these essential things, neonatal resuscitation, and they will evaluate health in newborns. So really, we are talking about relatively, sick babies, but well enough to be sent home, or sick enough to stay here, so that you can actually look after them in a particular way. Next slide. The next level of care is level 2. So we decided that level 2, WHO level 2, should actually be in general hospitals. And, subsequently, when we talk about level 2, we found that if we have district hospitals which are providing deliveries and they're providing operations, we might as well say that the district hospitals should also be providing level 2 care, so that when we go to the general hospitals start to be in between the level 2 as well as level 3. So for our level 2 care, we are talking about babies that actually require more than just just drying and stimulating. We are talking about babies who may require short-term ventilation as well as CPAP. So we said this was going to be happening. These are the current standards that we have. And the reference support would be to a level 3 neonatal unit, which would be in a level 3 facility. Next slide. So these are the babies that were to be nursed, the patient profile to be nursed in a level 2 care, which was like the general hospitals. And these are those that are requiring oxygen, but less than 40%, and they are needing CPAP and, would need surfactant, but would be given at this general hospital. Then at this point, we're thinking that we could have just those babies above 1,500 and above to stay here. But all these things, as we discuss, we need to probably revise. Okay. So when we look at the next slide, we are looking at level 3 care, and in level 3 care, we're really talking about the ICUs, where you care for the smallest and sick babies. Okay. And here the primary caregiver should be pediatricians or neonatologists, because this is like the highest level of care. They could even send some babies, like when the babies have been treated from level 3, they can be sent to level 2 to continue their treatment, so that the level 3 units are decongested. Next slide. So these are some big things that should be done at level 3 care, like ventilation, therapeutic hypothermia, which we are not doing, but even more advanced care. Next slide. So this is the slide. So basically, we were saying that when we have a level 1 that has got district hospitals, health facility, health centers, and health posts, we're saying which of these facilities should we actually implement what type of care. So as it is now, when we look at the WHO, we are saying that at the health facilities, we should provide level 1 WHO care standards. This is the essential newborn care, basically, for well babies. Then we have district facilities where we should implement level 2 WHO care, because at the district level, we should actually have a minimum of CPAP, because at district level, we are actually delivering different kinds. So if you look in our standards, you find that we've labeled the level 1 as the district being level 1A, the health facilities level 1B, then you have the health post and orphanages level 1C and level 1D. So basically, this is what we're saying. So we're saying that at the general hospital, we should be able to implement level 1, level 2 to level 3 care. At the district, level 2. And then at the tertiary hospitals, we should provide level 3 care. Next slide. Next slide. Okay, so these are the things that I'm talking about. We're saying that when we are looking at the health centers, rural or urban or zonal, we are saying that we are implementing essential newborn care. So at the health facility, this is where you just dry stimulate, give your vaccines and have the baby breastfeeding and send home. Next slide. Kindly mute your mic. Okay, so then for the district hospital, this is where we are saying, let's implement level 2 care, care for respiratory support, nutritional support, and care for, treating babies with jaundice. Next slide. Babies that are fitting and those that need clinical and supportive care, pain management, and follow-up discharge care. So all this is supposed to happen at different district facilities, because that is where we want to implement level 2 care. Next slide. Okay, then for the intensive care, this is where we are saying at both general hospitals and tertiary hospitals, we are implementing ICU care. So you notice that even when you go to facility level and you say you're implementing ICU care, please note that in the same ward, you can have a section where there are stable babies. You can have a section where babies are just receiving antibiotics, but then you should have an ICU that is actually treating the babies that are very sick. Next slide. Okay, so the other bit about tertiary hospitals and level 3 care is that there should be other subspecialties at the site. For example, like the surgeons, pediatric surgeons. So that is what should be the differentiating factor. Okay. Next slide. So generally, if we have to ask, where are we? Are we providing the level of care required at the respective facilities? I understand that some people may not even know what level of care that they are supposed to be providing. And as such, I would urge people to actually assess themselves and see what level of care they are providing. I think that's the end of my presentation. Thanks for your attention.
For ending on that really good reflective note of assessing where we are on levels of care for newborns. And now we'll move on to MOH national level statistics, and we'll hear from Mr. Silabwe Vicho, who has over 20 years of experience in clinical and public health implementation, coordination, and capacity building. He is skilled in planning, budgeting, monitoring, and evaluation in health programs, currently Chief IMCI Officer at Zambia Ministry of Health, Child Health and Nutrition Unit. Please do mute yourselves if you've just joined the call. Okay. He's the national focal point for early childhood development, ETAT, and pediatric HIV/EID. He is the former manager of planning and development at Central Board of Health Zambia and has managed national programs in maternal and child health, TB, leprosy, HIV, and regional resource person for IMCI computerized adaptation training tool. Over to you, Mr. Silabwe. Mr. Silabwe, just checking you're on the call. Okay, while we wait for Mr. Silabwe.
I'm sorry.
Thank you.
Internet connectivity was a
All right.
problem.
No problem.
All
Over
right.
to you, Mr. Silabwe.
Thank you so much. So I'll give the overview of newborn, basically on giving the current situation, how we are performing in terms of the indicators, as well as the causes of newborn death and overall child health mortality. So next slide. So we have made progress, of course, in the reduction of maternal and under 5 and the infant and newborn mortality rate. That's a fact from the ZDHS 2024. We have seen much improvement, and congratulations for all the technocrats and all those partners supporting the newborn. We managed to reduce the neonatal mortality rate from 24 to 17. According to the DHS last year. And then we still need to do a lot, considering the targets that are set before us, the SDG targets that Dr. Kunda referred to, and more so to our own National Health Strategic Plan, where we set a target to reduce the neonatal mortality rate to 12. We are talking about next year, and last year's results were at 17. We are hoping for the better on that indicator. But I want to mention that according to the MPDSR data in the country, every week about 10 to 15 women die from complications related to pregnancy and childbirth. But then the magnitude of the problem is that that correlates to the newborn death is that the data, same data, shows us that for each woman that dies, about 8 newborn babies are also lost. And furthermore, about 10 babies die as stillbirth. Next slide. So I'm giving a situation analysis to which I think all of us we are much aware of. So I've already mentioned on bullet number 2, and these are the efforts that are being made by all the partners to cater for the essential newborn care as well as advanced newborn care interventions, which are being implemented. And that's what has made us achieve that reduction. Then, however, as I mentioned, I want to just jump that we still have a challenge where stillbirths are concerned. Yeah, and the figures are as indicated there. And then we are saying every 30 minutes, a newborn baby is lost. Again, meaning that in one day, we are talking about 48 newborn babies being lost or dying. That's a major mountain that we have to dismantle as technocrats in the newborn family. So the major causes, we know them. It's birth asphyxia, prematurity, neonatal sepsis, and congenital anomalies or malformations. Next slide. So again, the process indicator, the immediate output indicator that we use as MOH, we're talking about the case fatality rate for the babies that are admitted with asphyxia. As you can see, we are making progress. When you see the color yellow and the green, at least there's something that is happening, but red means we are not doing very well. So we compare the case fatality rate of a certain particular year with the previous one, and then see whether the reduction is either below 15% or above 15%, where the death of the admitted children are concerned. So you can see for birth asphyxia, the case of 2024, on neonatal sepsis, again, congratulations. We are there at 75 in terms of case, 77 in terms of case fatality. But when you compare the years in green, meaning that we are doing well in this one, despite you seeing the figure being high. Then congenital malformations, we are not doing very well. It's like most of the babies who are end up dying, and we are in. Next slide. Next slide, please.
Because the baby.
The presentation is
1 hour is too much. Yeah. So 1 hour is too much.
okay. So I'm not going to take much on this one. These are trends for child and newborn impact indicators. I think I've already mentioned to the whole situation, especially for the newborn, but I've seen relatively a reduction in all the key 3 impact indicators for child survival. Moving to the next. This one, I leave it to the group to look at it. These are indicators that are related to nutrition. And I must say that we are still high prevalent. We need to update this one actually, because we are now at the 2 for the stunting and the less. So this one is oldest jump it. Next slide. When we look at the trends in assistance during delivery and delivery in health facilities, you can see the difference is just 1% there. We are doing fine. We are over 90%, and which is very good for us. Next slide. Please click again. When a newborn's dying, and the youngest are the most vulnerable. That's what this slide is actually showing. Click again, please. So we are saying up to 50% of newborn deaths occur in the first 24 hours. That's where we have to focus our attention on. And then the less within 1 week, about 75% of newborn deaths are also lost. Move on to the next slide. These are the causes, according to the global level, the causes of death in the first 28 days of life and the postnatal period. That includes also children under 5. I think the picture is self-explanatory on the pie chart. You can have a look at it later. Let's move on. Next slide. And this is our own picture for Zambia. So the situation remains the same. Prematurity is reading, followed by birth asphyxia. And I think I mentioned before other causes, but then the third one still comes like sepsis. We are doing fine according to the data that I presented earlier on. We move on. Next slide. So this is what we've already spoken to. So move on to the next slide. It's just a different way of presenting. Again, we're now looking at the still birth rate by province. The larger the bar that you see in these graphs, that's where the bigger the problem is. And you can see Northwestern province, there, having that situation. And the list, please, you can have a look at it. The list is Copperbelt. Congratulations to Copperbelt. We move on to the next slide. Still birth rate trend. We are doing fine. At least we saw the reduction from 2022 to 2023. Let's move on. Next slide. Why perinatal and neonatal mortality reduction is a global, regional, and also a national priority? It's because of the high perinatal mortality that we had, and the situation where the decline was not so much visible. So there was slower decline in the newborn death. And so we needed to look into it as a country, and also it's a concern at global level. Again, alignment, which again was already alluded to SDGs, and also every newborn action plan whose targets were set that we need to meet by 2030 or 2035, and also to have a single digit by 2030 in accordance with the ENAP targets. We move on. Every newborn action plan, I think this one was alluded to by Dr. Kunda. I'm just giving you where we are as Zambia. At least we're doing fine. We're above 70 for 4 or more antenatal visits. Skilled birth attendants, as I showed you already, we are above 80, we are doing well. Postnatal care, less than 48 hours, is supposed to be above 60. As a country, we have gone up to 65, as 85%. Again, we are doing well. We are just in red for the percentage of districts that are having a level 1, level 1, level 2 newborn care unit. Zambia, we only have at least 28 NICUs in the districts. Unless we have updated information that gives us about 25%. So we are in red for this particular ENAP indicator. We move on. Yeah. This one, I think for postnatal, I've already given. I can see from the graphical point of view that we are at least progressing well, and we are above the state targets as where ENAP is concerned. Let's move on. So just to give a picture on adolescent sexual reproductive health versus perinatal and neonatal outcome. Okay, so for maternal age less than 20 years, it's about 1.5 times in the neonatal mortality in terms of those who are dying in pregnant-related issues. And we are saying Zambia is among the highest adolescent fatality rate globally, and we are at 135 to 1,000 women. Then 40% of these adolescents have, sex between 15 and 19. Teenage pregnancies, we are 29.2%. And induced abortions in the girls 18 years account for 25%. Then children born to adolescent mothers at risk of infant mortality and no birth weight at 12% compared to 9% in the entire population. It's a worrisome situation. We need to work hard to prevent teenage or adolescent pregnancy. Let's continue. Maybe just giving the contributing factors to perinatal death from the supply side. Let's forget about the first bullet. I think for now the pandemic has ended. We have to move on the interventions that are not linked to COVID pandemic. So inadequate implementation of guidelines for continuation of essential services. After that, again, I've already talked about it. It's not an issue we need to talk about now, but we have inadequate appropriate treatment in most of the levels of care. On the supply side, let's move on. On the supply side, the factors contributing to perinatal death, we have stock out on medical and surgical supplies. So when you go, you may find certain supplies and medicine that are critical for management of the newborn. We find that they are not there. And then low staffing levels, inadequate skills to manage obstetric and neonatal complications. Even for the few that we have, we need to make sure that we give them the capacity necessary to save the lives of the newborn. The weak referral system is a fact, and that's why we are trying to say, can we propose that all district hospitals and all level 2 hospitals and the level 3 should have the neonatal designated ambulances? And I think where we started by doing that, buying some, and we're still expecting more to come to make sure that all these hospitals, they have a strengthened referral system for the newborn. And then we have inadequate infrastructure and equipment, which again was earlier on mentioned. So we move on. From the demand side, again, we are talking about inadequate utilization of sexual reproductive services, and then the myth and misconceptions, which are a fact for the newborn, low male involvement, and increase in home deliveries, although we are at 90-something, but they are still happening in a few, but we are moving in the right direction on this one. And then use of traditional medicine, especially in the management of labor. They give them some kind of traditional syntocinon, and those has its own, consequences in terms of management of labor. From the community to the facilities, we still have that weak referral system existing there, and then inadequate emergency preparedness at household level. We move on. Emerging challenges for neonatal and newborn care. We have urban disadvantage in big cities, where we have high perinatal death still happening even here in Lusaka. Home deliveries or any other places, again, there's that increased trend. And we needed to give that breakdown of what we mean, but we know that the institutional deliveries and supervisory deliveries are almost at 95 and 94%, which is good. Teenage pregnancies, I've already mentioned, high numbers. Then women living with HIV and also syphilis is a big problem. Equity issues, urban, rural, wealth, education, and geographical issues, these may need intersectoral collaboration to resolve, and it may not be the baby of the Ministry of Health alone. Cross-border challenges, and then back-to-back public health emergencies, which usually occur. As I move towards the last, we are talking about the challenges and opportunities. I think the challenges, we know them very well. And please, I beg that we can read this slide later on in the interest of time. We move on. Next slide, please. Okay. So the strategic pillars for reduction of neonatal death, those are the suggested critical interventions that we are supposed to do across each of the pillars, and so which are critical. We are talking about we need to address the issues of stillbirth, as well as the essential newborn care, and then move to sedation section plus blood transfusion care for small and sick newborn baby, and community care with facilities linkages. Those are some of the critical areas that we have to look into. Next slide. So we need to link the community to the facility, very important. We move on. So Zambia priority actions towards achieving the neonatal and maternal newborn health goals are as highlighted in here, and I may not read all these interventions. You have to maybe have access to this slide and then read. Next slide, please. What has been done so far? I think these were highlighted mostly by Dr. Kunda as well. But I wish to mention that we did a gap assessment for NICUs and KMC units in selected hospitals, support from UNICEF, as well as the Peace Health and the PIGO, FHN. We also have done a number of mentorship visits to provinces and hospitals and those designated centers of excellence for the newborn, and the less like procurement of equipment by UNICEF, which also catered for most of the levels of safe delivery to make sure that we improve where equipment concerned for management of the newborn. The less you can read, let's move to the next slide. Almost coming to the end. So strategies in use to improve newborn care. We have a supply side, we have capacity development, where we train providers in EMO, mentorship of healthcare providers and CBVs, strengthening provisional mentorship, advocacy for availability of essential commodities, and strengthening the referral system, as well as the telemedicine, including WhatsApp technology. We move on. On the demand side, strategies in use, where we have developed a number of IEC materials and community engagement through meetings, community sensitization, training the traditional leaders, community leaders and champions for safe motherhood, and strengthening the community structure like SMART, CBVs, and peer educators. Then we have done emergency and birth preparedness as part of the strategies to let people be aware at community level, including what I've already mentioned, to started procuring the neonatal ambulances. We move. So perinatal and newborn health in the pipeline, these are some of the things that are still pending for us to make sure that we cover all the service delivery levels and the districts with these resource materials and capacity building trainings. We move on. I think that was my last slide, and thank you, Chair. I think I was a bit fast, but because of the fear of the internet breaking that I have in the office. Over to you, Chair. Thank you.
Thank you, Mr. Silabwe, for that system-wide approach covering newborns and the maternal side, and basically showing that Zambia is steadily making progress in reducing newborn mortality and maternal mortality as well. From the high-level, national-level statistics, we'll move on to neonatal nurses now. And the next talk is on what is the Neonatal Nurses Association doing for ENAP Target 4 that we have heard a lot about already. And we'll hear from Samantha Munangandu, who is a healthcare professional with over 10 years of experience in midwifery and neonatal care. She founded and currently chairs the Neonatal Nurses Association of Zambia, holds a Master of Science in Neonatal Nursing, a Bachelor of Science in Midwifery, and an Advanced Diploma in Midwifery and a Diploma in Nursing. Over to you, Samantha.
Thank you so much for that introduction. Good afternoon, everyone. I'm here to enlighten you what Neonatal Nurses Association of Zambia is doing. So just to mention, Neonatal Nurses Association of Zambia came into existence last year when we registered it with the Registrar of Societies, and it was launched in February. So we can move to the introduction. Okay, so more than 2.5 million newborns, mostly those born small or sick, died in 2017 from preventable causes, and most notably prematurity, complications around the time of birth, infections, and congenital conditions. Some died because the care they received was of poor quality, others because they didn't receive any care at all. And this is globally, but it's also the current situation in Zambia. We are still having challenges of neonatal mortality. Next slide. So what is our goal as Neonatal Nurses Association of Zambia? So our goal is to improve neonatal care in Zambia. How? Through education, educating the nurses so that they can become specialized with neonatal skills and competences, and advocating for neonatal care and also professional development of neonatal nurses. Next slide. So what's our current performance? Currently, neonatal care is being provided in different facilities by different cadres. Neonatal Nurses Association is striving to ensure that high quality care is to be provided to all small and sick neonates through advocating for more opportunities for nurses to specialize in neonatal nursing. This is where we are engaging with Ministry of Health and Zambia Union of Nurses and Midwifery Organization to ensure that nurses are given opportunities to go to school to specialize in neonatal nursing. However, currently there's only 2 institutions which are training in neonatal nursing, which is University of Zambia, which is training at master's, and Lukon, which is training at diploma level. So what are we doing? We are advocating to ensure that more training institutions are open to train nurses in neonatal care. And this is currently happening. We'll see more schools trying to be opened to train nurses in neonatal care. Then also we are conducting research to provide evidence-based solutions to problems affecting neonatal care and their families. So neonatal nurses have conducted studies which have been published, and some are still underway. And the reason is we just want to ensure that whatever decisions that are being made are evidence-based. Thank you. Next slide. So we've come up with a work plan and objectives. So the first objective is to enhance clinical skills in neonatal resuscitation, infection control, and kangaroo mother care. And here we want to ensure that we do quarterly continuing professional development workshops. And also share latest research innovations and best practices in neonatal care through national neonatal nursing conferences. And we are happy to say that we'll have the Council of International Neonatal Nurses Conference on 14th to 15th August in August 2025. And this will help us enhance knowledge and networking. Then also the other objective is to lobby for improved neonatal intensive care unit equipment and policies, where this is ongoing, where we are advocating for neonatal equipment and policies with other non-governmental organizations. We haven't yet achieved this. It's ongoing. We are still trying to collaborate and advocate for this. The other one is to educate communities on neonatal care and prevention of preterm birth. So this one, it's done through community outreach and sensitization and different platforms, which it's done by every neonatal nurse at given opportunity, where we talk about neonatal care and prevention of preterm births. The other activity is where we are doing research and publication initiative, and neonatal nurses are being encouraged and they are being supported through mentorship, where when conducting research, so that they are able to complete the research and publish the research findings to help us to have more evidence-based solutions to our problems. Then also collaborating with Ministry of Health, UNICEF, and other stakeholders, which is ongoing, to make sure that we strengthen neonatal health care programs. Next slide. Okay, so this is something that I like, talking about a sick and small newborn. So this small and newborn, it's just a quote that reminds me to always remember that these are human beings. So I may be small, they are crying to us, all of us, but I'm not half a person. I deserve access to quality care, and quality care can only be provided when we have skilled, specialized, and competent workforce. Thank you.
Thank you so much, Samantha, for that really insightful talk. As we all know, neonatal nurses and nurses in general are the backbone of the hospitals, and in particular the NICUs and neonatal wards. So that was a very insightful account of how you're working across all levels to improve neonatal care through neonatal nurse capacity building. So from neonatal nurses, we'll now move on to a hospital example. So implementation learnings from Kapiri District Hospital, a UNICEF-supported unit. We're going to hear from Dr. Leah Seaman, who is originally from the UK, now based in Kapiri, Zambia for the past 10 years with her husband and 3 children. She works at Kapiri District Hospital, overseeing the neonatal unit, passionate about improving neonatal outcomes through low-cost, high-impact interventions. And her focus areas include KMC and early CPAP, and she is committed to developing systems for collecting high-quality data to inform quality improvement efforts. Over to you, Dr. Leah.
Good afternoon. Thank you for the introduction. So my job is really just to tell a story of one place so that you can see what's possible in the low resource setting, especially in the more rural areas. So if we can move to the next slide. So in 2017, Kapiri and Poshi just had one very, very small room, 3 meters by 3 meters for the neonates within the maternity ward. And basically there's a long list of what we didn't have. We didn't have nurses for the babies. So the midwives were trying to cross cover the special care baby unit, as well as the antenatal, postnatal and delivery suite. We didn't have hand washing facilities. There was no respiratory support at all. We were using adult IV giving sets. We didn't have guidelines or procedures. There was no phototherapy, and the warming equipment that we had wasn't functional. And actually what we found was babies were either being discharged early or there was quite high mortality rates. And equally, there were high mortality rates in the community as well, because when you looked at the admission numbers versus what you would expect, the admission numbers were actually very low. And there was a prevalent belief, especially in the community, that preterm babies couldn't survive. So a lot of these babies being born at home, they just never even made it to the hospital. Next slide. So what we did to begin with was just start with looking at what do we already have and what's the low-hanging fruit. And by that, I mean, what are the low-cost, high-impact interventions that we could do? And that took a bit of research. You have to read around, okay, who's doing what where? What's been proven to actually work in this setting? Because you can't just look at a neonatal unit, for example, from the UK, and just transplant that unit into a rural hospital in Zambia and expect that it will function in the same way. And so the first thing that we did actually was to buy a hand washing bucket for the neonatal unit. That was the first intervention. It was simple, but we know that these kind of interventions are high impact. We had a real focus right from the beginning on KMC, which I'll talk a little bit about, and we started to introduce basic respiratory support. And going back to what Samantha was saying, investing in staffing, so 24/7 staffing specifically for the neonates. When we did that, we saw a huge drop in our mortality rates. We developed policies and standard procedures and clearly visible guidelines around the neonatal areas and implemented what we call a bundle of care. And we're always careful. We've made mistakes along the way. We've found things that don't work and what does work, but to try to choose a low cost but high impact intervention that will have the greatest impact for the most number of patients. Next slide. So going back to the staffing, our neonatal mortality reduced significantly when we introduced 24/7 nursing rota specifically for the neonates. And it took us about 3 years of work to actually achieve that. So it was 2020 by the time we actually had that in place. But I really believe the nurses are the answer to the staffing challenges that we have in district level facilities. The nurses are trained to assess, stabilise and admit the neonates into the ward, and they are literally saving lives on a daily basis. There are protocols and procedures on the wall to standardise management. We have admission paperwork now that advises on the management and it guides on things like drug doses. And then more recently, we've also added the clinical officers into that group of people who are being trained to stabilise the neonates. Next slide. So going back to IKMC and KMC, well, we know, those of us who work in neonates, we know that kangaroo mother care has long been proven to improve survival rates in our setting. And this newer idea of immediate kangaroo mother care from birth, regardless of clinical stability, is also showing really great results in survival. We actually started doing it out of necessity because we didn't have warming equipment. But then we found that babies were actually doing better, and some of them were surviving where we didn't think they would do. And so we moved to make this our standard of care. And at the end of the presentation, I'll show you some pictures of a new ward that we've just commissioned in the last year. And it was actually designed around kangaroo mother care, facilitating zero separation from birth for all of our babies. But kangaroo mother care is low cost but high impact, isn't it? We need space, we need somewhere for mum to be comfortable, we need to provide for her needs, but actually the costs involved in it are quite low. But it can be challenging to achieve as well. You need motivated staff and you need motivated parents. And then alongside that, you need the warming adjuncts to support those times when mum needs to bath. Maybe mum's become unwell, she needs to go and be seen somewhere herself. Maybe she's eating and those things. So if we can move to the next slide, I'll show you some of the things we've found have been working in our environment. So when I first started in Kapiri, we had basically an incubator graveyard. We had a lot of equipment that just wasn't able to be fixed. It was old, the parts couldn't be sourced. We think that they were probably a source of infection as well. They were very difficult to maintain and very inefficient. So again, we began to look for solutions that had been designed for our setting, things that could withstand power fluctuations, power cuts, things that didn't take up a lot of space. And so these are a few pictures of interventions that we've found have worked. There's a portable infant warming nest that we've been using for around 4 or 5 years now. Works very, very well for the small babies. We also have some warming cribs that we've just started using recently. And then when we opened our new ward, which is a 38-bed facility, we actually just had 1 radiant warmer. We now have 2 and we're hoping to have 6 in the future. So these kind of pieces of equipment we've realised are really vital to maintaining warmth, to managing the babies when they're not in skin to skin with mum, but they're not aimed at replacing KMC, they're aimed to support it. And we're trying not to create any perceived barriers between the mum and the baby with the equipment that we bring in. Next slide, please. Also on the respiratory support, the first thing that we could do was bring oxygen for the babies. We had to get appropriate nasal prongs. And then we ended up making our own flow splitters out of IV giving sets. I'm sure quite a few people have seen that being done, but we know that's not ideal because we don't know which baby is getting how much oxygen. And so again, the investment was in simple things like a flow splitter for the wall so that we can actually adjust the amount of oxygen each baby's getting. We also started with the Pemani, the homemade bubble CPAP. But eventually we realized, again, we're giving a lot of oxygen to these babies. So we really need to kind of advocate and improve the type of machines that we're using. But again, choosing machines that have been designed to run in our setting, despite all the power challenges, the dust and those other things. All of these things can be done as well whilst in KMC. And then I've just put a little note at the bottom, caffeine citrate. I know that's something that's on the agenda for Zambia. It's not available everywhere all of the time. But again, I feel that's a really low cost, high impact intervention. Maybe not as low cost as we'd like, but hopefully that's something that will be worked on in the future. Next slide, please. There's also phototherapy that we mentioned and IV therapy. So if you're using an adult giving set for a neonate, they very quickly become overloaded. And what we found was that we couldn't safely give fluids to our babies using the adult sets. And we actually moved to giving 2-hourly boluses. But we know that's not great for many reasons. It's not physiologically great for the babies, and there's an increased risk of infection. So then we start looking for the IV burette, which again are better, but are quite difficult to regulate, especially for the very small babies. If you introduce a few kind of low-cost infusion pumps that are standardized, not too fancy with lots of different settings, but that just do what they need to do, you can improve the safety of IV infusions, and especially for things like giving blood as well. We previously as well had to refer for phototherapy, which led to delays and an increased risk of bilirubin encephalopathy. So when we were looking at phototherapy, again, we looked for equipment that has been designed for our setting. We currently have one phototherapy machine that's been running for 6 years without needing any servicing. It was recently tested and it's still deemed to be providing effective phototherapy. It was designed for our setting. It's been kept low cost for that reason. And so we need to start thinking about, when we bring equipment, choosing things which have actually been designed to run and not need a lot of upkeep and maintenance and extra parts. Next slide. And then the final thing, I think, is to focus on ongoing quality improvement. So to never feel like you've actually reached the pinnacle of what you can do, but collecting good quality data, which is relevant in the ward, can then highlight where you're being successful, but also where you need to improve. So we're currently using the data that we're collecting in the ward to inform our quality improvement work. You know, we noticed we were getting some non-breathing babies coming to the ward. Where are they coming from? What can we do? What interventions can we put in place that will result in an improvement? Or maybe there's some issues with aspirating on NG tubes. So we now have an NG training package for parents. We're looking at things like documentation. And so I think it's a case of, as well, despite making huge strides, always maintaining a mindset of looking for ways that you can improve the care being provided. There's always something to learn or some more places to make progress. Next slide. So I just wanted to show you that the mortality rates have fallen by percentage quite significantly, but you can see that the rise in admissions has gone from around 200 in 2017 in a year to 1,200 and something last year. So there's been a huge uptake in demand for the service at the hospital. Next slide. But I thought it'd be really interesting to also look at the mortality rates on all babies above 1 kilo. And remember that we also admit more stable babies that would stay in the district. But you can see where we put the 24/7 nurses in, there was a huge drop in mortality. And then at the end of the year, when we commissioned the new ward at the end of 2023, again, there was a huge drop in our mortality rates. Next slide. Yeah, and for the preterm mortality, things have also improved quite a lot. We're still working on the 1 to 1.5 kg category, but the mortality rates have really improved. So if we just go to the final slide, I'll show some pictures of the new ward that we've built through just fundraising and lobbying for the resources to do so. But I think just to highlight that you don't need the new ward at the beginning. You need to start with what you have, and then you spend the time just building up the service until hopefully you achieve something that is providing low cost but high impact interventions for all of the neonates. So thank you very much. That's the end of my presentation.
Thank you, Dr. Leah, for that really inspiring implementation learning from Kapiri district, and a big reminder that low impact, low level interventions can bring up high impact. So I appreciate you sharing that story from Kapiri. So now we'll move on to the Copperbelt Neonatal Network, another implementation learning, you could say, a provincial response to ENAP Target 4, where we'll hear from Ms. Priscilla Muziamba. Ms. Priscilla Muziamba is based in the Copperbelt Province, Zambia, and currently serves as Principal Nursing Officer at the Provincial Health Office, coordinating maternal, neonatal, and child health services. She is a professional midwife with 19 years of experience, holds a master's degree in midwifery and women's health. She's open-minded, data-driven, using weekly neonatal morbidity and mortality data to guide resource mobilization and implement cost-effective, evidence-based interventions. She collaborates with the Zambia Newborn Support Zambia to enhance newborn care in the province, and has played a key role in establishing the Copperbelt Neonatal Network to standardize newborn care and improve NICU services. Over to you, Ms. Priscilla.
Thank you so much, host, for the introduction. So can just go to the next slide. I think this slide has been spoken to by Mr. Silabwe from the national perspective. And as Copperbelt, being the second largest province that is contributing to the overall national picture, I think we also ascribe to the presentation as made by the earlier speakers. Next slide. Okay, so a brief background. As Copperbelt, we record the second highest mortality in terms of our MPDSR reports. And most of these deaths occur in high volume facilities where we have the second and third level facilities. In order to reduce the mortality, we joined hands with a Newborn Support Zambia so that we can create a Copperbelt neonatal network. The focus really of this network is to implement quality improvement projects in our facilities so that we contribute to a reduction in our neonatal deaths. Next slide. So that just shows a picture which was a cause of worry and alarm, why we thought we really needed to do things differently if we are going to turn the picture of the province in terms of neonatal deaths. So when you look from 2021 to 2024, you can see that we've had a steady increase in the number of absolute numbers of newborn mortalities that we record on a weekly basis. So these are just babies that we lose in the first week of life. Even though the number of deliveries that we conduct have been increasing steadily, and this can contribute to a slightly lower rate in terms of newborn mortalities when we compare to the number of deliveries, we feel using absolute numbers to indicate how many babies we are losing gives us a clear picture of how the magnitude of our problem, so that we are able to put in interventions to reduce not just rates, but absolute numbers of babies that are dying in our facilities. Next slide. Okay, I think this slide too has been spoken to. Of course, the only thing to note here is looking at the picture and the number of babies that we continue to lose, we thought we needed to work with a Newborn Support Zambia as a province to put in interventions and initiatives to improve the state of newborn care in our province. Next slide. Okay. So working with the Newborn Support Zambia, we identified gaps. Obviously, the focus was to look at where we are as a province in terms of our level of care. are we in level 2? Because that's when you look at our hospitals, that's the barest minimum we can be as a second level, third level facilities in terms of implementation of our neonatal services. Maybe to just give a background, as a province, really we have 10 districts. And if you are going to look at ENAP target number 4, it's expected that 80%, which is 8 of our districts, should have a level 1 hospital, should have a level 2 hospital, a district hospital that is implementing level 2 services. But to mention is that we just have 6 hospitals, 6 districts which have NICUs, which are just Ndola, Kitwe, Mufulira, Chingola, Karusha, and Luansha. And the other 2 districts just have SCABs. We also have 2 districts, Lufanyama and Masaiti, which do not even have any neonatal unit at all. So an assessment was conducted, and based on the analysis of those results, we found that even our facilities that we are calling level 2 and level 3 in terms of establishment of tertiary or general hospitals, when we made an assessment, all of them were falling short of 1 or 2 indicators for them to meet the criteria of a level 2 facility. So based on those assessments, we identified a number of gaps, one of them being undefined neonatal levels of care. So units may be housed in tertiary or secondary level hospitals, but they were not meeting this classification. There's also inadequate space for care of small and sick newborns and implementation of KMC, inadequate life-saving equipment and commodities, inadequate skilled teams to care for sick and small newborns, poor actionable data collection, and poor post-discharge follow-up of our small and sick newborns. Next slide. So based on this, we had to come up with a strategy to improve newborn survival as a province. And we thought the next strategies can help us improve newborns, improving access to quality newborn health delivery will prevent negative neonatal outcomes, adequate healthcare financing, which is cardinal in ensuring that we have the following are available: relevant personnel, skills, equipment, infrastructure, equipped ambulances service, which are dedicated to newborn care. So those are some of the two main strategies that we are looking at as a province. Next slide. Okay, so in response to the 6 gaps I earlier highlighted, we are looking at strategies that we can use, focusing on each gap to reduce neonatal mortalities. So on the gap for undefined level of care for our facilities, where you have units which are in a tertiary hospitals, but inadequate neonatal care services for that level of care, we are classifying neonatal levels of care, which will help us allocate resources in terms of equipment, skills, commodities, and improve our referral system. So there's a health facility assessment tool that we are using, and to implement this, there's a finalized health facility assessment tool that we are implementing in all our places where we have NICUs, and also facility assessment to have a baseline that will inform optimization of our care. So basically, the first gap is just to see where are we right now in terms of level of care, and based on that, we have a foundation for the implementation of our activities. Next slide. The second gap is inadequate space for care of small and sick newborns and implementation of KMC. So the strategy we are using here is just to identify facilities that require repurposing of space on new buildings, and we are doing on-site and off-site assessment of NICUs. So with this already, we've even in facilities where districts where we've not had neonatal care units, we've identified some spaces, for example, in Masaiti district and Ufanyama district, which we are currently working on to just have them equipped. And before we end the second into the third quarter, we should have operational neonatal units in these spaces. We are also identifying already established hospitals like Chifubu level 1, Chimwemwe level 1, which were not really being fully utilized in terms of implementation of neonatal services, so that we make them fully operational and find a way of having more children sent there, since they have facilities that can help our newborn care, newborns to have positive outcomes. Next slide. On gap number 3, inadequate life-saving equipment and commodities, our strategy is to create a bundle of care to improve newborn survival. And to do this, we are looking at providing life-saving equipment to the network. We lobby for equipment from partners, train healthcare workers so that they are able to use donated equipment. We train health workers in the use of commodities such as caffeine, citrate, and surfactant. As we are going to see later, I think some of these activities are already being implemented. We are going to highlight what we've done so far as a province. Next slide. Okay, so the initial minimum required equipment. So as a province, we saw that majority of our facilities, especially the second level and first level hospitals, did not have CPAP machines, and they were relying on Pemani CPAPs, and not all of them actually were even implementing the Pemani CPAP. So working with the network, with the Newborn Support Zambia, we actually had a marathon where we were able to mobilize funds. And I think the most prominent partner that we had was KCM, which helped us to procure 50 CPAP machines. And these CPAP machines have been distributed in our facilities as a province. We also were lucky to receive a donation of 60 units of Embrace incubators through the Newborn Support Zambia. We are also looking at how we can have phototherapy machines come on board, resuscitators and infant warmers, infusion pumps, syringe drivers, as well as pulse oximeters and cardiac monitors, as we continue to lobby to have all these, as these were identified to be some of the most prominent missing equipment in the majority of our NICUs. Next slide. So under gap number 4, inadequate skilled teams to care for the small and sick newborns. Here we are looking at creating a newborn care team at each facility, okay, and also leadership and governance. So activities to do short-term trainings of health care workers in care of small and sick newborns, and long-term training for health workers. That's where we have advanced diplomas as well as degrees in neonatology, so that we have specialized manpower to manage our small and sick newborns. Next slide. So the 5th gap was poor actionable data collection. And here we are looking at having a standardized data collection tools in all our NICUs, so that these can be used for effective analysis of care of a newborn, a sick and small newborn. So the activities will involve a data review. Okay, that review collected data, where we are able to look at the admission forms, the ward round sheets, and also this should help us create a database, because majority of the time when we are talking about negative outcomes and so on, it becomes very difficult to provide evidence of where the gaps are and what are the most prominent problems, because most of these data sets are described in abstract. So we want to have a system where we are able to collect data which we can use to inform our decisions, and also use it to lobby for what may be missing elements in our care. The next slide. So the 6th gap being a poor post-delivery follow-up of small and sick newborns. Here, the strategy is to set up an outpatient follow-up clinics in health facilities for small and sick newborns. In fact, we hope to extend this kind of follow-up at community level, where we can have people who are assigned within the community who are trained to be able to help us with the follow-up of baby sick and small newborns in the community as well. So the activities are to identify a space where we can do these follow-up clinics. And I think the follow-up clinics don't necessarily have to be in a neonatal intensive care unit hospital, even at district level or at high volume facility level. We need to have these skills where people can easily access follow-up care for their sick and for their small and sick newborns. We also want to set up registers for all newborns who are being reviewed so that we are able to look at how they are improving and so on. We find that the majority of the data that we may have would be data of that baby when they were within our healthcare system. But for a province like ours, where we may have babies that are coming from maybe the next district or the next town and other remote rural health centers, you find that once that baby is discharged, that may be the last time that you know about their outcome. But we want to account for the outcome of each neonate that we nest by having this post-discharge kind of information up to the time we feel they are safe enough. We also want to ensure adequate information is given to parents before they are discharged. Next slide, please. Okay, so to achieve all this, we came up with a Copperbelt neonatal care network, which is being implemented. So the structure of this network consists of neonatal units which care for small and sick newborns. And the setup is that the team leads will identify teams at their facility. So if we have, for example, we have a team lead at Ndola Teaching Hospital neonatal unit. That team lead should identify a team within the facility which are going to spearhead all matters pertaining to newborn care. And this team should be all encompassing, where we are looking at every person that will come in contact with this newborn at the point of delivery and beyond. So we want to include obstetricians, midwives, nursing staff, and everyone else that is working in a neonatal unit, as well as theaters. Our hope is quality newborn care should not just start when this baby is taken to a neonatal unit, but this quality newborn care should start at the point of delivery. In fact, even way before delivery, where we should be able to identify which woman in labor or which woman antenatally will require additional neonatal care services at the point of delivery, so that we have a team that is ready to receive this newborn and put in interventions to optimize their outcome in the long run. So all the members of the team will be added to a WhatsApp group for ease of communication. So already we have a Copperbelt neonatal care network, which has been established. So currently we have the team leads and a few people who are pioneering or as a steering committee. But our hope is these team leads now should form teams within their hospitals, where we have all these other cadres put together, and where we'll be able to account for what each team is doing at every facility. Next slide. Okay, so among the activities that have been done so far, we have the health facility assessment using the HFA2. We do weekly. So we thought that having the MPDSR meeting at provincial level, where we combine maternal and neonatal care, you find that much of the attention will be given to a maternal death, and very little time will be given to a neonatal mortality or a neonatal case review. And so we decided to separate the two meetings, where we hold a maternal review meeting on a Wednesday and we hold a neonatal review meeting on a Friday, so that we give each component the attention it requires. We're also conducting in-person training for hands-on practice. We review a review of our data collection tools, baseline data collection for each facility. We also implemented a multi-sectoral MPDSR committee, which is chaired by the provincial minister. And this committee is also at a district level. We've put the district commissioners as the chair. So in our MPDSR committee, we have all the leaders of the districts, all the leaders of the hospitals. And when we held our latest meeting in January, I think the Copperbelt provincial chair, the provincial minister, really made an emphasis to say we are making strides towards reducing maternal deaths, but he bemoaned the number of babies that we continue to lose. And the call to action in that meeting was the focus now should be, when we meet in the next meeting, we'll focus more on what we are doing in improving newborn outcomes. Next slide. Yes, so this is how we are monitoring and evaluating our progress. We have our weekly meetings to update ourselves on tasks. We also have our perinatal and newborn mortality meetings, and also be conducting monthly quality improvement project meetings in newborn care. So projected partners, obviously the Provincial Health Office, Vandetta, KCM, the ones that put a CPAP, actually they were open for more support, especially that we show that we are making improvements with what they've given us so far. We have also pharmaceutical companies, Sonnet Diagnostics, as well as other well-wishers. So the identified facilities, we have Ndola, Kitwe, Luansha, Mufulira. So when you look at all these facilities, these are facilities where we have a NICU, but also scabs like Mpongwe and Chilabombo, we just have scabs there. But also extending this, as I already mentioned earlier, that we've already started assessing Lufwanyama and Masaiti district for possible opening of scabs there as well. Next slide. So what has been done, I think I was mentioning as I went, self-accreditation by conducting that assessment. We procured 50 various CPAPs. We lobbied for 100 embrace incubators and were able to receive 60. I think 40 went to Central Province. We launched our Copperbelt Neonatal Network on the 4th of April. And when we received the various CPAP, we conducted a training which involved people from NICU as well as our biomedical equipment officers, so that they are also aware of how the machines should be operated and maintained. We also, after we did this, we did cascade trainings in all the facilities that received our CPAP machines. With certain facilities training almost everyone, we had facilities training as many as 100 people, 40 people, so that everyone is aware of how to use the various CPAPs to be able to implement or to start a CPAP even at a point of birth. We also, our first review meeting was held a month post-acquisition of the equipment to just see how each equipment, how each facility was managing the equipment. And obviously others were doing extremely well, and others projected certain challenges they were facing, especially when a mortality or something like that is recorded while a child is on CPAP. Others seemed to want to go back to Epimani, and then we thought we just keep encouraging each other as the presence of a CPAP does not mean that the child cannot die from other causes, as well as a separate MPDSR meeting every Friday. I think that's where I end, Chair. Thank you so much for your attention.
Thank you, Ms. Priscilla, for that really insightful and learning experience from the Copperbelt Neonatal Network. I'll now hand over to Dr. Helen for the Q&A session before we close this webinar. Over to you, Dr. Helen.
Okay, thank you so much, Dr. Spalo. I would like to thank the Newborn Support Zambia team for this good and insightful presentation, and would like to commend you for the work that you are doing in order to reduce the neonatal mortality in our country. So I would like to open it up to questions, comments, clarifications. So you can just raise your hand and unmute yourself. Then you can go ahead and ask the question.
Chair, my hand is up.
Yes, Mr. Silabwe, you can go ahead.
Chair, it's not a question. I just want to commend you, the Pediatric Association of Zambia and Newborn Support Group. This is what we want, to hear the feedback of what we are doing, what you partners and technocrats are doing to improve the welfare of children and the newborn and whichever category of population that we're responsible for. I think that's what we need. I don't know how long does it take to have such a meeting like this again? Is it quarterly or when? Maybe that's my question. But otherwise, I'm so happy. I've learned a lot, very insightful. And thank you for organizing the webinar. That was my comment, and probably try to answer my question, how often do we expect to have such meetings? Over to you, Chair. Thank you.
Okay, thank you so much, Mr. Silabwe. So majority of the work was actually done by Newborn Support Zambia, and we'll have a sit down with them again and decide when we'll be having such meetings. But as ZPA, we are open and we are able to accommodate the Newborn Support Zambia anytime. But maybe, we'll still discuss in the background, but maybe quarterly would be more appropriate. But we'll still discuss in the background and give you feedback, more concrete feedback. Thank you.
I
So
think
any other? Yes, Dr. Spalo.
I think that would be a good moment to perhaps close this really good and informative webinar. Dr. Helen, what do you think?
Okay, so we have a comment in the chat from Dr. Patricia Bobo, so I'll read it. Thank you to all the presenters, very informative presentations. I need to log off and move to another meeting. Just a few issues, just to let everyone know that the just ended 78th World Health Assembly has adopted a resolution that now entails that WHO will incorporate the World Prematurity Day on its official calendar. This comes with a number of recommendations, including the need to report by all member states of WHO on progress made in various areas to future WHAs. Thanks, and look forward to more interactions like this. Okay. Okay, I don't see any hands raised from our participants. I think we'll give the floor to Dr. Kapembwa to give her last comments, and then we'll officially close the webinar. Thank you.
Thank you. Thank you very much, Helen. Thank you, ZPA, for this platform. I would like to thank all the presenters. And I think from all these presentations, I think the take home should be that we have to really endeavor to know what level of care we are providing and whether that's the appropriate care. We are happy with the Kapiri journey, and for me, the take-home point is, let's start with what we have. We won't have everything, but let's do the little things and start measuring how this, these little interventions are actually working. In terms of the neonatal nurses, I think that it's a challenge that people should allow, the nurses to go to school. The one thing I like about the Copperbelt Provincial Health Office is their flexibility to allow staff to actually do training. We've been able to implement the advanced diploma, the postgraduate diploma in neonatology on the Copperbelt, because they were very open-minded, where people have to travel to actually come and look at a unit and have the training. So if we do those things, small steps, I think we will get there. Thank you, Mr. Slavwe, for availing yourself despite your busy schedule. And thank you, Neonatal Nurses Association of Zambia, for rising to the occasion. And thank you, Dr. Spalo. And bye, everyone.
All right. So with those remarks, I declare the webinar closed. Thank you very much, everyone, for making time to attend. Have a lovely day.
Thank
Thank you so much.
Thank
Bye-bye.
you.
Bye.
Bye. Thank you.